Hi, everyone. Good morning. Nice to see you all. Welcome to our inaugural Grand Rounds for the academic year. Very excited that today we celebrate the Mark Babiatsky Lecture Series, and welcome to Dr. Babiatsky's family who's on Zoom, and thank them for all their support over the years. And with that, I will turn it over to Dr. Sands to introduce our presenter.
Thank you, David. Good morning to everyone. Welcome back to live medical Grand Rounds. Really wonderful to see living bodies in the same room together. And I want to thank the Department of Medicine for supporting this very special occasion. And it's my pleasure to welcome you to the 7th annual Mark Babiatsky, MD Memorial Lecture, which is very special to me and to many of us to honor Mark's memory. And I'd like to spend a few minutes remembering Mark and what he meant to all of us. So Mark was raised in a really tough neighborhood in the Bronx, but he rose to the top in everything that he did. He attended Bronx High School of Science, very difficult to get into, and then was awarded his bachelor degree from Columbia. Then he went on to get his MD from Einstein, and he graduated as a member of AOA. He completed internal medicine residency and chief residency at the Mount Sinai School of Medicine in New York, as it was then called. And his impressive performance in residency was recognized by Dr. Kurt Isselbacher, legendary gastroenterologist, and Daniel Podolsky at Massachusetts General Hospital. And he did GI fellowship training there in the gastrointestinal unit. After his fellowship, Mark continued at MGH as a junior faculty member, but in 1994, he returned to the Division of Gastroenterology at Mount Sinai and continued his studies in the laboratory on mechanisms of mucosal repair and inflammatory bowel disease. While he was successful in the laboratory, he really found his true calling and quickly became one of Mount Sinai's most cherished and distinguished educators. He won numerous teaching awards and was known for mentoring medical students, residents, fellows, and postdoctoral scientists. And in 2002, Mark became the director of the Internal Medicine Residency Program and co-program director of the Internal Medicine Pediatric Residency. He was also vice chair of education. And for the next 8 years, Babs, as he was affectionately known, nurtured and promoted the careers of over 400 residents and fellows, a remarkable record. His teaching rounds, known as Babiatsky rounds, were the highlight of the week for all interns and residents, and everyone knew they would come away with a trove of clinical pearls. Mark earned national recognition among internal medicine program directors, and he became founder and director of the Education Research Consortium of Program Directors, and working with the American College of Physicians as a member of the In-Training Examination and Education Research Committee, and as an ACP representative to the NIH's Genomics Consensus Conference on developing a blueprint for primary care physician education in genomic medicine. And then in 2010, Mark rose to become chair of the Samuel Bronfman Department of Medicine and professor of medicine at Mount Sinai. In early 2014, he assumed new challenges as the chair of medicine at Monmouth Medical Center and St. Barnabas Medical Group South Region to develop systems for providing high quality and cost-effective care. And a few words really about Mark as an individual. He embodied the keenest physician skills. He had an innate ability to mentor and guide trainees. He had an effortless talent for teaching and really an enviable and incredibly accessible body of knowledge, not just for medicine, but really for life. And what distinguished Mark from so many gifted scholars and educators in medicine was his caring, compassionate personality and his genuine interest in every person he met, from student, resident, fellow, to patient, family, or friend. And everyone who knew Mark felt as though they had a really unique and close personal connection to him. And we were all the better for having had him among us, and we miss him deeply. So now, in his memory, it is truly my distinct pleasure to introduce the 7th annual Mark Babiatsky MD Lecturer, Dr. Susie Rose. Dr. Rose is Senior Vice Dean for Medical Education at the Perelman School of Medicine at the University of Pennsylvania. After her bachelor degree from University of Pennsylvania, Dr. Rose received first her Master of Science in Education, a clue to what would come, from the University of Pennsylvania, followed by her medical degree from Case Western Reserve, where she also completed residency in internal medicine, followed by fellowship in gastroenterology, and serving as that institution's first woman chief fellow. And after an initial appointment to the faculty of University of Pittsburgh, then briefly at Cornell, where she was director of the GI motility program, Dr. Rose moved to Mount Sinai in 1998. Here, she ascended the ranks to become professor of medicine with tenure and of medical education. She also held a series of roles as Associate Dean for Academic and Student Affairs and Medical Education, as well as CME. And in 2011, she moved to UConn as Senior Associate Dean and Chief Academic Officer for Education, and in 2018 to her present role at Penn. And I'm sure I've missed a ton of accolades along the way. She's served in many leadership roles in the AGA, including as education counselor on the governing board. She convened all 6 GI societies to create end-of-training and trustable professional activities, co-created the first subspecialty academy for educators in this country, served as co-director of the AGA Future Leaders Program, and was appointed course director of the AGA's postgraduate course in 2017. She was honored with the AGA Distinguished Educator Award and completed a 2-year term as co-chair of the Northeast Group on Educational Affairs of the AAIMC, and so on. There are so many things that I really couldn't say it all. But in short, Dr. Rose is a big E educator. She's an educator's educator. And given Mark Babiatsky's dedication to medical education, it is a true pleasure and totally appropriate to welcome Dr. Susie Rose as this year's Babiatsky Lecturer. Susie, welcome back to Mount Sinai.
Good morning, everybody. Good morning. Hey, good to hear you guys. It is such a thrill and such an honor for me to be here today. And we're going to spend some time talking about the UME to GME transition. I apologize to my GI colleagues. There's no poop or defecatory dysfunction today, but we can talk about that later if you'd like. I think I forgot to turn this on, but I have a booming voice, they tell me. So I have no disclosures. So Mark, to me, was a mentor, an advisor, a teacher, an educator, a leader, a clinician. And I learned early on that he was a Holocaust educator. We actually connected on this because my mother-in-law was a survivor of Auschwitz. And he was also my friend. And oh my gosh, I can't remember how many years ago it was, but Mark went to Hawaii and he came back and knew that I collected turtles. And he brought me these lava coasters, which were very, very, very special to me and are still special. We're still in the process, those of you who know me, my husband retired and we're a living apart together couple for, I think 11 years, finally moving into one apartment. So these coasters were packed so carefully and are in storage, but they're about to come out in about a month, and I just can't wait to see them because it just reminds me of Mark's presence and his friendship. And giving this talk just means so much to me, and you know, I feel a little bit emotional about it because of who Mark was. So you already heard a little bit about my Mount Sinai journey, but I just want to say that I feel like I grew up here in many ways, as an educator, as a physician, as a person. This was the place where I achieved my goal, which I told my first boss I wanted to be in a dean's office by the time I was 40, and I wanted to be promoted to professor by the time I was 50. And that happened October 31st, the night before my 50th birthday. So I made it within like 12 hours. I also, that was just so important to me, as well as the tenure, which I've now given up at Penn. We don't really have tenure at Penn. We have different tracks, and I'm on what's called the CE track, which is essentially the tenure track. But this place means so much to me. I've learned so much. I have so many amazing friends from here, and the connections are really tremendous. So let's get on with it. As an educator, I can tell you what my learning objectives are. They're in behavioral terms, you'll notice. But by the end of this time together, you should be able to identify the components of the continuum in medical education, evaluate the challenges of transitioning from UME to GME, and develop innovations to tackle the identified challenges. And here's my agenda. I want to talk a little bit about transitions in general, define the continuum, talk about factors that affect medical education today, and the hot topics across the continuum. We'll talk about unique issues related to the UME GME transition and really delve into the 9 themes of a major report that came out of the coalition. And we'll talk also a little bit about the literature. It's only been like a year or so, so there's not that many papers about the UGRC report, which I'll tell you more about, but we'll cover those. And then I really want to tackle some of the special issues that we think about. The length of training, you know, does it have to be this long? Do you have to be like 35, or if you're an MD PhD, 43 by the time you're done? What about the boards, student debt, wellness? And then we can talk about some next steps. So I know a lot about transitions. You already heard my story, but this is like all the places I've been. So I have transitioned a lot. I actually find transitions to be invigorating. And every time I move, and I'm not moving again, this is it for me at Penn. I was just telling Bruce that I give myself like 7 more years. And I have some things that I want to do to really make a difference in medical education before I go. But I've been a lot of different places, and the longest place that I've been has been here at the Icahn School of Medicine. So, you know, why am I so interested in transitions? I actually, you know, oversee all of education in UME and CME with a link to GME at Penn, and I accompany all the students during their times of transition. Whether it's the white coat ceremony, whether it's the first week of school. I just spent an hour with our students last week as they transitioned into anatomy. Because that's, for some of our students, that's their first experience with death. It's a scary experience for many. And why are transitions so tough? Well, there's a lot of hope as you transition, but there's also fear of the unknown. And that creates anxiety. There's excitement, but also self-doubt, depending on what you're transitioning to. Even in anatomy, can I do it? Am I going to faint? And it can be hectic, because when you transition, sometimes you're moving, sometimes you've got little children that you have to move with you. And so, you know, in general, transitions can be very hectic. But there's some special issues in the UME to GME transition. UME, the 4 years of medical school, GME, residency and fellowship. And that has to do with like the age of the transition. This is a really important time for those who are transitioning. Many people are, you know, thinking about their family or growing their family or thinking about their next step personally. Location is important. There's the cost behind them of medical school, and then the cost of like, oh no, do I have to buy a home? What to do? What's my significant other going to do? There's family issues. Sometimes children are involved. And there's competition, you know, at the medical school level, and we'll talk a little bit more about this. It can be very competitive as you're going through this process. So I just want to make sure we're all on the same level here. Our medical students hate being called UME. They feel like they were just undergraduates, and then they're undergraduates again. But this is the lingo that's been adopted for a gazillion years. So UME is the 4 years of medical school. GME, again, is residency and fellowship. And most of the time, a physician will spend in CME. It's like 80% of your career is in CME. And that's something that we've been paying more attention to lately. So there are a lot of factors that are affecting medical education now. Each one of these could be a lecture for an hour in and of itself. The explosion of scientific information. We can't keep adding stuff into the curriculum, whether it's for a student, whether it's for a resident. It can't be additive. You have to pull something out. Advancing technology, that's both in medical education, but also in medicine. Changing healthcare systems, the complex skills that physicians really have to be able to tackle. Complex decision-making now. The rising student debt that we've already mentioned. Demographics for patients and physicians. The value of the millennial and post-millennial learners. We have to really learn to appreciate that and really come to terms with that whole balance and well-being. And we also have a better understanding of adult learning theory that I tried to portray on the right, but it's really this, it's not like a talking head just talking at you all the time. It's having relevance of material, and for medicine, it's so easy because there's the whole clinical breadth of material, right? But also it's more than relevance. It's action. It's being actively involved. It's getting feedback, even though feedback may be tough. And we now understand adult learning theory, and many medical schools have changed their pedagogies to team-based learning or team-facilitated learning or problem-based learning. And many residencies now are in rounds and in other venues are using more interactive techniques. So there are a lot of hot topics in UME, GME, and CME. I can't go through them all because, again, they each take like an hour to talk about. But the SCOTUS decision about no use of race in admissions is something we're all tackling with. Competency-based education, technology, portfolios, how do you follow your students, debt, and the fourth year of medical school. What is that all about? In many schools, it's like a waste, but it's 25% of your medical education. What about in GME? Well, our residents just unionized a couple of months ago. It was a really big deal. I'm not sure how the impact of that will go. There are going to be some positive things for the residents, but also some negatives. So, you know, for example, if you have somebody on maternity leave and they want an exception and extra time, you can't do that when you're under union rules. So it's going to have some pluses and minuses. We already mentioned the length of training, duty hours, supervision versus that ever wanted autonomy, and then core competencies, milestones, and EPAs as a way to sort of track your education and your accomplishments. In CME, some similar things. The maintenance of certification is very real. Bridget and you and I worked on how to come up with a different model. And the model that we came up with now, like 9 years ago, is something that actually the boards have put into place, which is more relevant learning, things having learning where you can be asked questions, get immediate feedback, and don't have to take the every 10-year exam. There's the balance of the in-person and virtual offerings. You can see that here. I understand that about half the people are online. And what we learned at Penn is that we were able to double our attendance at all grand rounds and also all educational venues. So why not bring more people in? But there's some disadvantages related to interaction and people seeing each other in person. And then there's additional requirements for DEA. That just came out in June, more opiate training, interprofessional opportunities, and more skill-based updates for clinicians. So all of this is coming together as we think about the transitions across all of these areas. And even though there are special issues involved, they're all really interlinked with each other and really affect each other. So why choose for today to focus on the transition from UME to GME? Well, first of all, it's timely because of the recent report, which we'll be talking about. It impacts the Department of Medicine in a very significant way, and that's where we are today. And it really speaks to Mark's passion in medical education. As I thought about this and spoke with the residents about what a good topic might be, really honoring Mark by talking about students and talking about residents was what I really wanted to do. So these are the reasons why I chose this topic. And you know, what I found out is it's really interesting. So first of all, there's the application to residency. There's too many applications. I don't have to tell our program directors here that you're going to get hundreds, and some places are getting thousands of applications. What do you do with that? There's grading changes in medical schools. Many schools are going to pass-fail in the clerkships. How do you differentiate students? The MSEd, formerly known as the Dean's Letter, the Medical Student Performance Evaluation, has turned into really nothing. It's very limited. There's very little information. Originally, it was created in around 2005 to be implemented in 2006 so that you would be able to have comparative performance data on students from the same school, but that hasn't worked out. Some programs have templated LORs, letters of rec, some don't, and now we have signaling. Oh, some of you may know what that is, and some of you may not. What that is our applicants, our student applicants can now sort of put points, essentially, on programs that are really important to them. And students are very wary about this, like who's going to see what they're doing? What if they don't signal one program? Does that mean that they're not likely to get in. The couples that are matching are particularly worried about this because often they're applying to 8, 10 places together, even more than that. And so you can't signal that many programs in both specialties. And beyond that, we have the interviews, the match, the unmatched students with SOAP, the single entry date in GME in July. Why does it have to be a single entry date? And if we're talking about individualized education, does it make sense anymore? It's a complex ecosystem. There's so many organizations involved, and I'll show you that in a minute. And then there's tension. I kept hearing this word and seeing it in the literature. Tension is everywhere between the students and the programs, between the students and affairs, between the student affairs and the program directors. And how do we approach that tension to bring something positive out of it? Well, I've already mentioned this, and the Coalition for Physician Accountability, and you can see like all the organizations on the right in very small letters, but alphabet soup. Their purpose is to advance healthcare and promote professional accountability. And they do that by improving quality and efficiencies and continuity across the board in education and training and in clinical medicine. So in 2020, this group formed a committee to really look at the UME to GME transition because everybody felt that it was broken and they're trying to find solutions. So a 30-member committee was established, a committee across the board, program directors, educators, students, residents, clinicians, even patient advocates were there. And they identified the future ideal state for GME. They talked about the root cause analyses of what the challenges were in GME. They sought a lot of feedback on their report, and they published an initial report for public comment, and then they modified the report, and they reviewed the literature, and eventually they came up with 34 recommendations in 9 buckets. So, and the report is, close to 200 pages long, and it's an interesting read, and you might agree with some of the recommendations, but not all of them. But what I'm going to do is go through each of the 9 themes. I'm not going to go through each recommendation, and we'll go through them one by one to talk about them and to see what the issues are in the UME to GME transition. So the first one was collaboration and continuous quality improvement. And this, they really felt that you needed to have a personalized and a safe, really, environment and experience for learners with a balance of multiple diverse groups. So residents coming together, faculty coming together, and students coming right out of medical school into a residency program where there were more advanced residents. They were concerned about criteria for evaluation, not just while the student was a student, but moving into GME. And that brings up questions of equity when you talk about evaluations. And so the overall theme, which had a couple of recommendations in it, was to focus on improving the process for everybody, for the learners, for the programs, and for the schools. And to do that by focusing really on 2 things, well-being, and you're going to hear about that a lot, and minimizing financial burdens. And here's the alphabet soup that we talked about. And if you just think about it, those of you who were students recently, who are students or residents now, you know that there's just all these groups, the RRC, the ACGME, the matches, NRMP, SF match, the MSP, the AMA, the AAIM. I mean, all of these different things are coming to light and affecting this whole process. And I just love this like alphabet soup help. Because I think that's where we need a lot of help, bringing everybody together and sort of on one playing field. So theme 2, which we see throughout the continuum now, is a focus on diversity, equity, inclusion, and making sure that we leverage resources, that training regarding anti-racism and bias is included. And you know, what's going to happen in the political arena and happen in every state, we don't know. The SCOTUS decision was very focused just on admissions, but there have been warnings out there that the focus may grow and may affect education at some point. And then recruitment strategies to increase diversity across the continuum. And again, admissions may be affected in the residencies. And in fact, as we're looking at the SCOTUS decision at Penn, we're including not just UME, but the residencies and making sure that holistic reviews are across the board without using race. So theme 3 was about trustworthiness, advising and resources, improving resources, reducing competition, differentiating specialty-specific advisors. So students would have advisors within the student affairs office, but they may not know how to advise a student in orthopedics, as an example. So in each of the departments, we need to have specialty-specific advisors, and those advisors need to be trained. They need to be trained about the UME experience, what the students experienced as a student, and also what they will experience as a resident. Going along with this, and credit goes to the AAIMC and to Lisa Howe, who works at the AAIMC, who shared this graph with me. This was the influence of various factors on the specialty choice of graduating medical students. So, in the blue was moderate, and in the darker color, it's strong. So the strongest is personality fit. That's what the student wants going into residency. After that was specialty content. So, we are seeing students applying in both OBGYN and surgery as an example, because they're looking for the personality fit. Work-life balance was important, role model influence, and then equal was fellowship training options. And you'll see that less important were the things that come at the bottom here. But it's important for advisors to know this, but this is across the board. And for any single student, it's going to be 0% or 100%. So you have to ask that student, what is important to you as you apply to residency? And you have to have that discussion in order to apply appropriate advice. So theme 4 was outcome framework and assessment processes, defining common frameworks and competencies for learners as they go across this transition, making sure that the student is ready for the transition. The AAIMC established EPAs for the end of medical school, but there really aren't common assessment tools. And with Step 2 CS going by the wayside during COVID, there really aren't clinical assessments to say that this student is prepared clinically and is a good communicator to enter the environment. So we have to train our faculty to be good assessors, but we also have to think about having assessments across the 156 plus medical schools. We also have to recognize and mitigate bias. We're using, as I'm sure you are in some of the studies you're doing, natural language processing using AI to look at bulk of evaluations using key terms. And what we're finding is bias. We're finding that there are words in the clinical arena where women may be called nice or sweet. And there are also terms that affect race. And so what we're gonna have to do is look at this and train our assessors to make sure that they are aware of bias when they write narrative assessments. So this is all new. You've seen some publications about this, I'm sure, coming out of some of the subspecialties across the board. I know there's some in pulmonary, but I think you'll see more about this coming out of the UME literature in the near future. So theme 5 is away rotations. So, when I was in student affairs here, our students used to do 3 away rotations in orthopedics if they were going into orthopedic surgery. And I was thinking to myself, oh my goodness, that's crazy, because they're going to be doing orthopedics for the rest of their lives. So shouldn't they be seeing something else while they're in medical school? Well, they can't, because the orthopedics evaluators were going to be looking to see whether they did research, to see whether they did 3 away rotations. And we have to fix that. We have to kind of normalize that across the board and really explore, like, what are the goals of away rotations? Is it really to audition? Is it for the student or is it for the program? And it's costly. There are some programs that are supported for underrepresented students, but students that are going away for three away rotations are paying for their rent here. Sometimes they're able to sublet, but not always. They're paying for their rent wherever they are. They're paying for plane travel or train travel, and it becomes quite costly to do away rotations, especially at a time when in the past we were also paying for interviews which were away. And it's still unclear where the interviews are gonna fall out. So theme 6 was equitable mission-driven application review. So let's improve that VISP. Let's ask our program directors, the end users, what do you want to see? What is going to be most helpful to you? And it may be different for different programs. I've been thinking a lot about the evaluation of our students in clerkship. I don't think it should be pass-fail, but I also don't think it should be honors, high pass, pass-fail. I think we should have 10 parameters, and for 8 of them, you are the typical Sinai student, and for 2 of them, you're exceptional. And maybe you're exceptional in basic knowledge or in communication, but maybe that's what's a better fit for that program. And we're looking at maybe converting to something like this. The other issue with evaluation in clerkships is that the person that is teaching you is evaluating you at the end, right? So if you screw up in the first week, but become the best medical student in week 8, they're going to remember that, and you're never going to do well. The story I'd love to tell is when I was a fellow, I was terrible at doing endoscopy. For the first month, I just couldn't get it. I couldn't get the spatial thing. And Mike Sivak, who is a premier endoscopist, was my teacher, and he was like, I don't know if you can do this. But at the end of my residence, at the end of my fellowship, he said to me, hey, Rose, you're a first violinist. Nobody in my shop is a concert mistress because I'm the only concert master. But you're a first violinist and the guys are all second violinists. So at some point, I turned a corner and I became the endoscopist that people went to if they couldn't finish the colonoscopy. But it took me a while. So sometimes it takes a while, but if he had just remembered how awful I was in that first month, I might not have gotten a good evaluation at the very end. We probably should replace our letters of recommendation with these templated evaluative letters, and we have to think of filters. So some of you may or may not know that residencies were able to filter. You could pick, you got to have a step 1 score of 260 or I'm not going to look at your application. Now step 1 is pass-fail. So what do? Well, they might look at step 2 CK. I mean, it seems like that is like the newest thing. So there's always something that can be used to filter applicants, and we have to think about that as we think about this transition. So theme 7 was optimization of the application interview and selection process. We've got to reduce the number of applications, figure that out. We should have standards for interviews, and we should really think about the impact of virtual interviewing and whether that works, because it's a high cost save, and I know that the resident wants to see the program, but there may be other ways to do it by having visits in groups rather than have individual interview days. So something to think about, and something that really hasn't been solved yet. Theme 8 is educational continuity and resident readiness. I love this one. So we definitely have to improve our GME orientation. What's your orientation like? I thought about it for the medical students. The first year I came to Penn, medical students were in line for ID cards and their iPads and this and that. And I'm like, they're in medical school. This was their dream for life. And so I made it important that they see their first patient on the first day of medical school. And it's a story of science and discovery and a story about a patient. This year, they heard from Dr. Sarah Gill, who talked about CAR T cells for treating a certain type of leukemia. Students took a break, and then the patient came in, and there was not a dry eye in the audience, and the students will never forget that first day of medical school. We have to do that in GME as well. This is something, an advancement in your career, a transition. It should be marked not by getting an ID card, not by getting your epic password, but by really thinking about what your future holds in education. So, there needs to be a feedback loop to the medical schools about how their students are doing in residency. We have to develop resources for program directors, coaching as necessary. Coaching is just another topic that I am enamored with. We now have academic coaches and professional coaches at Penn. We actually pay them to help students that are having challenges and difficulties, and the results are just amazing. And we also have to provide knowledge and skills training during the final year in medical school. We talked a little bit about that. What is that fourth year of medical school for? It's not just for applying to residency. You should be learning medicine in that fourth year and figuring out how to do that. Well, there's more here on theme A. This is the resident readiness project. It was a pilot about 2 years ago. It's now been instated. We've been using it, and what happens is the AAIM will send the residency program an evaluation tool, and the school gets to hear back, things like, was your Ms. P useful? The answer for most schools is no. And then, how well is your resident doing? Did your graduate do well? And this is just a graph. In the blue, it's exceeded overall performance. Green is met, and red was in trouble. Not such a good resident. And maybe you didn't tell us the whole story. So think about this here at Mount Sinai. Are your residents ready? And this is adapted from an article and shared with me by Lisa Howe, that our residents have multiple needs. They have physiologic needs, relocating, maybe buying a car, financial security, practical needs. They have to get their license. Learning a new electronic health record can be very challenging, as you all know. Legitimacy and belonging, meeting new colleagues. It can be scary. Learning new routines, getting your cohort, your support system together. Competency, clarity on the new role. And there can be a sense of imposter syndrome as a student enters residency. Do I belong here? Am I ready to be autonomous in a certain way? Am I ready to teach medical students? And that autonomy thing is something that we see throughout the continuum of medical education. Our medical educators, our students, our residents just love having some autonomy. And here's the last theme, health and wellness. Those resources have to be available. There has to be enough time between UME and GME for an appropriate transition, and financial planning has to be a big part of this. And this came from one of the organizations from the National Academy of Medicine adopted this. The 6 essential elements for worker well-being is to advance organizational commitment, strengthen leadership behaviors, and leaders should model that behavior, conduct workplace assessments, examine policies and practices, workplace efficiency, and cultivate a culture of connection and support. I think that's the part that's most important. And it's very difficult to do, and it really depends on the leader to do that, to create activities so that people get to know each other and to rely on each other and to trust each other for the support that they will assuredly need during residency training. So how do groups look at these 9 recommendations? Well, the AAIM has provided a statement. It's online, but I'm just going to summarize it for you. That we need to co-create with our learners this positive, personalized transition. So they were all in favor of that. But it's going to be a challenge to balance the multiple needs of multiple groups, that whole alphabet soup. That we have to ensure reliable, efficient solutions, and we actually have to work with residency programs and the learners together. Analyze any innovation that we put into place to make sure that we assess it and that we are scholarly about it. And focus on improving the process for everybody, including well-being, and again, you're seeing it again, well-being and financial concerns. That's like a theme that rises to the top in all of this. So the AAIM has certain recommendations for UME to GME transition. And this was just published this year. And what does the AAIM say? It's the Academic Society in Internal Medicine, that there's no standardized curriculum right now on the transition, and we need that. They recommend topics based on domains that are critical for both patient care and for professional development, both. They're both important. And the development of standardized assessments. So we're seeing the same themes over and over again. The AAIM recommends an ILP, an individualized learning plan. And I know in some of your residencies here, you already have that. In some of your fellowships, you already have that. The NIH is now requiring that of our PhD candidates. But you should really express your goals, your preparedness for internship as you enter the transition, areas you might improve in, core preparedness in internal medicine, and desired learning experiences, like what you hope to accomplish over your 3 years in the residency. So the IOP will look at all of these factors, and this is published in their article. I recommend that you look at it. There are some interesting ones here. The one I really love is recognizing when to ask for help. And the one thing that I learned as a resident is you're never really alone. There's always somebody you can call, another resident and attending. So, but there's also the very nitty gritty, like how do you obtain consent for a patient procedure? So all of these are things that we need to identify that our residents need to be able to accomplish, make sure we assess them on it, and then say, check the box, you're able to do this. The other thing that they ask is a very important question. Which 3 core IM topics do you feel least prepared for during internship? And I love this question because the learner is able to self-assess either through how they did on the boards, how they did with patients, what their overall assessment was, even from their pre-clerkship years. You know, do they need more work on cirrhosis or pneumonia? Do they need more work on shock? Or is it something that's not on this list? So identify those 3 things. Make a plan so that you have the time to learn those 3 things really to perfection, because it's all about patients in the communities that you're going to serve. You have to bring it to perfection. So I want to talk about some special issues before we end up here. The length of training, board, student debt, and got to have that wellness in there again. So does training have to be that long? I'm not going to answer the question. I'm just going to pose it, and maybe we'll have a few minutes to discuss that. But this is the MD, or what we call the MD plus student, the student that graduates with an additional qualification, like an MBA, an MPH, or another master's or a certificate program. You know, the students now are coming in after a gap year or 2. They may be 24 years old. By the time they get to their first job, they're in their mid-30s to 40. Is there anything that we can do to change that? What about the MD PhD student? Look at that student. That student comes to matriculation, sometimes has 6 to 8 years in medical school, becomes a resident and fellow, does some research time, does a postdoc, we call that the waiting room, waiting for their first job, and they're already in their mid-40s by the time they're junior faculty, and by the time they get their first RO1, they could be in their mid-40s. Doesn't have to be that long. What can we do to fix this pipeline? Next question, what about the STEP exams? So we're done with Step 2 CS. What's going to come down the pike? Step 1 is now pass-failed, but Step 2 CK is not. So do we tell our students to take it before you apply to residencies because they're going to use that to filter you? These exams were made to ensure the public that the student was knowledgeable and ready to go out and take care of patients. It was not intended to say this student is ready for this particular residency program at Mount Sinai. And so we shouldn't be using these tools really to say, is this the right fit for us? We should identify what the best fit for our programs are and then figure out how to evaluate that and make sure that we let our UME colleagues know how to determine the best fit. Student debt. We mentioned this a lot, financial issues. it's just rising. So student debt now is over $200,000. It definitely has an impact on career choice. And that's a huge chunk of change for somebody who may be wanting to start a family, for somebody who may want to be buying a house and knowing that they owe that much money. And it takes quite a bit of time to repay that. So it affects them for many, many years to come, and their family, and things like even vacations and the whole wellness piece, which is important to talk about. I just want to give you a couple of really important facts to say that this is important. 30% of medical students and residents self-report depression. 10% express suicidal ideation. 60% of residents at some point in residency have burnout, but only a third of the medical students who experience depression or burnout seek help. And why is that? And we're only talking about depression here. The number one symptom for students and for residents is more likely to be anxiety. And how do we address that? And what is the cause of that? And are we doing something that is affecting that? You know, after, yesterday was 9/11, and I was here on that day downstairs in the student lounge with students who were signing up with different languages, waiting for patients to come who never, ever came. But I remember the dean at the time saying that this day will forever change our lives. And I think that's true. Students now have a more worldliness. The whole world is like their neighborhood. And the things going on in the world, the political situation, is that creating some of the anxiety, or are we creating it in the process as we make these transitions challenging and difficult? It's hard to separate those out, right? So, and then I just want to mention the learner perspective about the transition. I will leave some time for questions. But the learner has work-related concerns and personal concerns. They have increased responsibility. They're learning new processes, a new place to travel, and learn the tunnels, and learn the electronic health record, how to get around. But they have career anxiety, like what am I going to do with my life? Their family, how am I going to adjust to this new location where I'm in? So I just want to mention that I found 2 or 3 articles since the coalition report that have been published that all relate to tension. And the tension is really described of at odds, UME to GME, between the student and the program and the school, and the school and the student. And it's also a tension between, and this has been since I was a resident, like what is service and what is education. And then, the match process can position an individual choice over the needs of the workforce. So as we add match positions in dermatology as an example, do we need more dermatologists or do we need more primary care physicians? We should be focusing on what our patients and our communities need. And there's a tension there. The trainee as an advocacy for transformational change. I've heard it said that students are transient, they're here for 4 or 5 years, so how much does their opinion count relative to faculty? Their opinion counts because they're in the trenches and they can give you incredible feedback. The same thing for the trainee in a training program. And this article purports that what is going on in this whole situation might be solved by having resident groups look at this and be change agents for good change for the UME to GME transition. And finally, this is a bare bones fishbone diagram because I didn't want to give you the whole thing. It would have been very difficult to see. But these fishbone diagrams are often used to look at root cause analysis. And this root cause analysis article focused on the root causes that were identified by the article and the study, which is bias, costs, culture, lack of standards, and lack of alignment. So I have some provocative questions for you. And I think we have 5 minutes where we might answer a couple questions before I end. So how many of you think training has to be that long? Does training have to be that long? As long as it is? Yeah, how about some of the residents? Do you think you could get that earlier? Do you need the time? Oh, you guys can't be that quiet. One opinion.
I think you're commenting about the fourth year of medical school. That's priority.
Yeah, the problem if you trim that is how do you then, in a very busy third year, and a lot of clerkships now are either after 12 months or after 18 months, but how do you leave time for application? And the other question I would ask is, does there have to be one entry point into residency? Does it always have to be July 1st or thereabouts? So do we have to stay with that July 1st entry? And how would we accomplish if we're truly doing individualized education? And we had this discussion, Bridget, when we were in Chicago working on the GME milestones. If a fellow is able to do the procedure and is clicked off and checked off as competent, they still can't do it without the attending, right? So what does that mean that we're individualizing education? So is there a way that we could have different entry points and advance our learners at different points in time? And maybe that would be after residency and not before medical school, but we should be thinking about that. How do we address the multi-generational differences in values? And all of you have experienced that. Sometimes it has to do with the wellness piece and time off. I think COVID changed everything because we used to come to work like deadly sick. You know, we'd go to work with a fever of 102 and our nose is dripping and we wouldn't go home and we might put a mask on to take care of a patient, but gosh, take a day off? Like never, right? And then how do we implement and track a competency-based educational program? We addressed that a little bit, but do any of you have any ideas about that? Besides having an electronic portfolio that will track it or some other mechanism?
And I think if we get better in our HRs of attributing, finding how to attribute care, we can be able to metrics to do that. That's very far off. That would probably be also programmatically allow schools to see the impact of their graduates in year to year.
No, it's a really great suggestion. And I think one of the things that many of us are challenged with, and the AAIM tried to do this years ago, was a portfolio that you would get on the first day of medical school that would follow you for your entire career. And we don't have that, but it would be ideal to have that because, you know, as that question asked in the ILP, what were your 3-week areas? There are always areas that you're going to have to work on, right? And so it's something that we need to think about. And I think about it now as I continue to do my MOC, which is still 30% liver, and I haven't seen a liver patient since 1990. But as I, pick up that question that they give me 4 minutes to answer, it's like, oh my gosh, I don't really know the answer to that. But I've been having some fun learning more about liver diseases. So here we go again. There's another transition to fellowship, but I'm not going to talk about it. But there is a document from 2022 that those of you that are going to be making that transition or are in it might want to look at. So our next steps are that UME and GME really have to work better together. We have to focus on those competencies and simplify the regulatory alphabet soup oversight. And we really have to keep the education of the learners at the forefront. And sometimes we forget to do that because we're so mired in the process. And actually, it's not just the learners at the forefront, but it's the patients and the communities that they serve. So life is one big transition, and transitions are a time for reflection and a time for looking forward. I would look at it as positive. And this is really special for me because this is my first time back after 12 years of being at UConn and Perelman, and I love Mount Sinai. I love it here, and as I told you, I grew up here. And I just want to bring us back to Mark. This was really created in loving memory to Mark, to honor his memory. And I think together, as we think about these transitions, we can make a difference. And I'm going to be reminded in a very thoughtful and memorable way positions moving forward. So I thank you for your attention, and I'm here to answer any questions that you may have. I think we have like 1 minute. Thank you.
Thank you, Dr. Rose. So Dr. Rose took us through some questions, but maybe a comment or question now?
Susie, thank you. You really honored Mark so nicely. So proud to hear your thoughts. I'd like your opinion about something that I think is missing from this entire conversation, and that is accountability to our communities that we serve. What is the role of people who live in our catchment area in all of this? Julio in the Med Peace program here has a member of the community as a voting member on their resident selection committee. They have a voting authority. I think it's a really smart idea because we do all of this in a vacuum. We think we know what the community needs and wants, but are we really getting their input in, especially the GME transition? We're now training people to take care of people. Where are the people that we're serving in all of this?
Oh, it's such a great question. Everybody here, could you hear Steve? He's got a booming voice too. So, I think the community is crucial to this. The problem that we always have, and we have it with students, we have it with residents, we have it with community members, are we sure that the voice we're hearing really represents everybody? And so when I'm talking to a student leader from medical student government, I always have to ask, is this your opinion, or are you representing, did you talk to everybody, did you represent the opinion? And I think that's the biggest challenge with a community member, making sure that they represent the community. I actually think they might do a better job than the students and the residents. We've had community members on our admissions committee. We actually wanted to put a community member on our student standards committee. That's our committee that needs to promote students and graduate them, because we want to make sure that they feel ensured that the student is ready for graduation. So I think it's a brilliant idea. I think we should all embrace the idea, and I think it's actually great to involve the community, to let them know how hard our students and our residents work. I mean, our students and our residents work really, really, really hard, and I don't know that the community understands that, and it's on the community's behalf. So I think it has a lot of good purposes to it, and I think the way to start is by including them on the committees. Even interviewing, I think could be a role. You just have to make sure it's equitable, that everybody gets sort of the same type of interviewers. That's a great question.
Thank you, Dr. Rose. So I'm going to bring us to an end and invite others to come up and talk to Dr. Rose for a minute afterwards, and want to really thank the Dr. Babiatsky's family who's with us on Zoom, and really honoring his memory with Dr. Rose's excellent talk on UME to GME transitions. And we have a wonderful plaque to present her after this in honor of, for your office at Penn. So thank you. So join me in thanking Dr. Rose, please.